Hey everyone, welcome back to our channel. Today, we have a fascinating and important topic to discuss: the epidemiology and outcomes of hospital-acquired bloodstream infections in intensive care unit patients. We'll be taking a deep dive into the findings of the EUROBACT-2 international cohort study, which sheds light on this critical issue in healthcare. If you're interested in the challenges faced by ICU patients and the strategies being employed to combat antimicrobial resistance, you're in the right place. Don't forget to hit that like button and subscribe to stay updated with our latest content. Let's get started. Hospital-acquired bloodstream infections are a major concern in intensive care units around the world. These infections can lead to serious complications and are associated with a staggering 36 to 42% mortality rate among ICU patients. One of the key factors driving this crisis is the growing prevalence of multidrug-resistant organisms, which was highlighted by the EUROBACT-1 study back in 2012. In recent years, antimicrobial resistance has become an even greater concern, as it leads to delays in adequate treatment, increased mortality, and higher costs for healthcare systems. This vicious cycle of resistance has necessitated the use of broad-spectrum antimicrobials, which unfortunately further exacerbate the problem. This is where the EUROBACT-2 study comes in. Its goal is to update our understanding of the epidemiology and factors associated with day 28 mortality in ICU patients with HA-BSI. The study collects data from ICUs worldwide, focusing on patient and pathogen information, as well as treatment and outcome data. By identifying potentially modifiable factors of poor prognosis, the findings of this study can help inform patient care, guideline development, and the design of future clinical trials. So, let's take a closer look at the methodology and key findings of the EUROBACT-2 study. The study is a prospective international cohort study that adheres to the STROBE guidelines. Interestingly, this study was conducted during the first year of the COVID-19 pandemic, and the differences in the epidemiology of HA-BSI in patients with COVID-19 have been reported separately. The study focused on adult patients, aged 18 years or older, who were treated for HA-BSI in the ICU. HA-BSI was defined as a positive blood culture sampled more than 48 hours after hospital admission, and treatment in the ICU was defined as either the blood culture being sampled in the ICU or the patient being transferred to the ICU for the treatment of the HA-BSI. For organisms usually considered as common contaminants, at least 2 blood cultures with the same antimicrobial susceptibility profile or strong clinical grounds that it was not a contaminant were required. The operational committee, in collaboration with local investigators, carefully reviewed all possible contaminants for eligibility and excluded those that did not meet the criteria. The EUROBACT-2 study enrolled 2,600 patients from 333 ICUs in 52 countries or territories. The majority of ICUs were public, teaching hospitals with a mixed medical, surgical and general case mix. Most patients were male, with a median age of 64 years, and 74.8% had at least one comorbidity. The median time from hospital admission to HA-BSI was 13 days. Most HA-BSIs, that is 78.5%, were acquired in the ICU. The median SOFA score at HA-BSI diagnosis was 8, with 4% of patients not meeting the criteria for sepsis. 64.2% met the criteria for sepsis and 31.7% for septic shock. Infection sources were predominantly respiratory, that is 26.7%, and intravascular catheters, that is 26.4%, followed by the abdomen, that is 15.1%. Most blood cultures were monomicrobial, with gram-negative pathogens being the most common, 59%. Carbapenem resistance was encountered in varying percentages across different pathogen species. DTR was present in 23.5% and PDR in 1.5% of the analyzed pathogens. Adequate antimicrobial therapy was received by 51.5% of patients within 24 hours of blood culture sampling. Time to adequate antimicrobial therapy increased with antimicrobial resistance. Source control was deemed necessary for 52.5% of patients and was effectively achieved in 81.8% of them. By day 28, 966, that is 37.1%, patients had died, with 91% of deaths occurring in the ICU and 9% after ICU discharge. In summary, the study provides valuable insights into the epidemiology and prognostic factors of HA-BSI in ICU patients across 5 continents. The study found a substantial day 28 mortality rate, especially among patients with HA-BSI caused by DTR pathogens, those in septic shock, and those who never received adequate antibiotics or source control. Gram-negative bacteria were frequently carbapenem-resistant or DTR, and antibiotic resistance was associated with longer delays to adequate antibiotic administration. While the study has some limitations, such as a predominantly European and high-income country sample and potential differences in laboratory interpretation, the findings contribute to the understanding of HA-BSI in ICU patients and emphasize the need for a multidisciplinary approach in managing these patients. The conclusion of the study highlights that HA-BSI in ICU patients is primarily caused by gram-negative bacteria, with a significant prevalence of carbapenem resistance and DTR. Antibiotic resistance leads to longer delays in administering adequate antimicrobial therapy. HA-BSI is associated with a 37.1% mortality rate, and by day 28, only 16.1% of the patients had been discharged alive from the hospital. In conclusion, the study on HA-BSI in ICU patients emphasizes the urgent need for improved prevention, recognition, and management strategies to address the high mortality rates associated with these infections. By adopting a multidisciplinary approach, implementing antimicrobial stewardship programs, and focusing on antimicrobial adequacy and source control, healthcare providers can work towards improving patient outcomes. As we continue to face the challenges of antibiotic resistance, it is crucial to invest in research and innovation to develop more effective treatment strategies and stay ahead in the battle against HA-BSI and other healthcare-associated infections. Together, these efforts will contribute to a safer and more effective healthcare environment for all patients.